Thank you, Dr. Ali. The last speaker today, Dr. Brahim, is consultant pediatric neurologist at Prince of the Military Medicine City. He's also a professor at Faisal University, and he's specialized in neurometabolic and genetic disease. We'll talk about pediatric genetic and metabolic disorder.
Thank you very much for this nice introduction. Thank you, Dr. Ali, and the organizer for the invitation. It's always my pleasure and honor to be with my friends, geneticists and metabolic. So I think everything was said about metabolic and genetic disease, so I will only highlight a few issues about pediatric and the challenges what we have. So this is my objective. So one is what are the emerging issues in pediatric neurometabolic and neurogenetic disease, and the second objective is the challenges we face in the care of those patients with metabolic and genetic disease. So we know already that metabolic and genetic disease are common, mainly in the region, 3, 4, 5 times more higher than other region, and associated with a lot of morbidity and mortality. And that's why I think early diagnosis and treatment, if available, is extremely important to improve the care of those patients. So in pediatric, we are familiar with two main phenotypes for neurometabolic disease. The first phenotype is what we call the intoxication, and the patient will present with acute encephalopathy, coma, seizure, and he's very sick, and mainly in the newborn or early infancy. The second phenotype is mainly regression of myostoses. So the patient is normal till a certain age, and then he will start to lose his skills. In the recent years, we are more familiar with emerging phenotype. So we have a new phenotype for neurometabolic and neurogenetic disease, mainly in terms of epilepsy. So usually if you have a patient with unexplained epilepsy, difficult to treat, epileptic encephalopathy, we have to think about metabolic and genetic disease. The second phenotype, as mentioned by Dr. Ali, is movement disorder. So movement disorder also, we have a big group in pediatric, whatever we have dystonia, ataxia, or a combination of those. It's most likely also the genetic. And another very important and interesting phenotype is what we call the cerebral palsy phenotype. So the patient will present exactly at the cerebral palsy with a little progression or non-progression at all, and turn to be one of the metabolic or neurogenetic disease. We have the example of AADC deficiency, succinate arginase deficiency, etc. Ataxia telangiectasia may present as CP phenotype, etc. So I think it's very important beyond the classical clinical phenotype to recognize that those phenotypes may also have an underlying metabolic and genetic disease. Phenotype. So this is a patient with tyrosine hydroxylase deficiency and presented what we call the oculogenic crisis as one part of the movement disorder. So this is a patient with very bad dystonia and turned to be one of the transporter of manganese, one of the treatable condition with chelation. So this is a patient considered for many years as cerebral palsy and turned to be one of the primary coenzyme Q10 deficiency, treated with Q10 with significant improvement. So the other, as a clinician, what we have is the neuroimaging, and neuroimaging for us is extremely important with the clinical phenotype because we can have the diagnosis with the clinical and neuroimaging. I don't have laser, but the first A and B is a classical in children with adrenoleukodystrophy, the X1, So the C and D with the metachromatic leukodystrophy, and you see in the D the diploid pattern. Just select a few ones. The L is the PCAM, neurodegeneration with brain iron accumulation. The N and D is what we call the Migdal syndrome, and you see the putaminal I, N and D, is associated with 3-methyl-glutaconic acidemia. So combining the clinical phenotype and the neuroimaging, this is extremely important to guide the biochemical testing and the genetic testing in pediatrics. So from pure genetic point of view, those diseases are very common in pediatric. Joubert syndrome with classical molar tooth syndrome, corpus callosum agenesis, which is non-specific and can be seen in a wide variety of disease. The last one is very common in the NICU, the Walker-Warburg syndrome, and every week we have a new case, very difficult. We have also advanced in laboratory testing. So classically, we have the classical biochemical testing. More and more, we have the next generation sequencing, and also very interesting to use the next generation metabolic screening and omics techniques. In some cases, are extremely helpful. So let us speak about the common entity, at least in pediatric and our daily practice. The first one is epilepsy, and we have two main groups, the metabolic epilepsy and pure metabolic and genetic epilepsy. So regarding metabolic epilepsy, interestingly, the glucose transporter defect is extremely rare. So for the last 15 years, I have only one case. So it's not so common in our region, GLUT1 deficiency. However, all related to vitamin B6, pyridoxine-dependent epilepsy, whatever, anti-ketine or other genes, are extremely common and very important. They respond very well to pyridoxine plus L-arginine or lysine restriction diet. But we have also other type of metabolic epilepsy, whatever related to the CAR deficiency, recently described, the PIGA, the PMPO, and other folate deficiency. So regarding genetic epilepsy, and this is extremely important, just to compare, this is from 25,000 gene in the Western. This is a multi-center study we published a few years back. So we have three main differences in the genetic epilepsy. The first one, most of our cases are recessive as expected compared to de novo in our other region. The second one, which is extremely important, is the yield of genetic testings. Our yield is around 60% compared to 35 to 40. And the third one, if we look to the common genes, so we have different genes, for example, what Dr. Ali about sodium channel is not, at least in our study, is the third one, it's not the first one. So what we have very common is SSC13A5, which is linked to citrate transporter defect and other genes. So the genes are a little bit different in the term of classification in our region compared to other regions. So, and why is it extremely important to have genetic diagnosis in epilepsy, not only for metabolic treatable or genetic counseling, but we can apply our anti-seizure medication according to the variant, and this is extremely important. So the same, we have many studies now recently published how the genetic testing will impact our decision to treat. So another disease which is more specific to pediatric is the thiamine transporter defect. So this is just to summarize. So the thiamine to enter to the cell needs transporter. And we have 2 or 3 main transporters, SLC19A3, SLC19A2, etc. And within the cell we have other thiamine transporter, SSC 25A19, etc. So the most common one is the SSC 19A3, which was described by Ozan and King Faisal in 1998. So, and this is what we call the biotin-thiamine responsive basic ganglion disease. We have now more 75 patients with biotin-thiamine responsive basic ganglion disease, and classically the patient will present with acute encephalopathy, seizure, dystonia, ophthalmoplegia, and this typical MRI. So if you see this MRI, this is a typical for SSC 19A3, bilateral symmetrical basic ganglia, thalami, cortical, subcortical, high signal, etc. So if you see with acute encephalopathy, we treat with antibiotics, but think about vitamins and start as soon as possible vitamins. So leukodystrophy in Saudi Arabia, so my colleagues spoke about that, but just to mention three things. So this is a multinational, multi-center study we did with Dr. Merja Father a few years back. And what is interesting that if you look to the Jizan region, what is in green, so they have almost only caravan disease. So caravan disease all came from here. So this is one. So if we look to the metachromatic leukodystrophy, 50% or 45% are related to the non-classical form, which is non-treatable, which is Saposin B deficiency. And this is very interesting. And the third interesting point is that ALD, the classical adrenoleukodystrophy, is not common in Saudi Arabia. So this is also very interesting to highlight this. So I will not speak about mitochondrial disease. NCL are very common, especially in this region, type 5, type 6, type 2. So what about treatment? And classically, we know that the treatment will be based on gene therapy, if it's available, on enzyme replacement therapy, or on metabolite vitamins or cofactors. So, and treatment in metabolic and genetic disease is more and more goes to what we call precision medicine. So if we consider Dravet syndrome, which is most of the time loss of function of this gene, SNCL1, the most important is not to look for the best anti-seizure medication. The most important is to avoid that the anti-seizure may worsen the seizure of the patient. So to avoid sodium channel blocker. And then to look what works better in this syndrome, mainly stiripentol, fenfluramine, or cannabidol, waiting for potential disease-modifying therapy as antisense oligonucleotide therapy or others. The same thing applied for glucose transporter defect. We have to avoid sodium valproate because it may cause exacerbate the seizure, and the treatment is not anti-seizure but is ketogenic diet. The same, Dr. Ali spoke about disease-modifying therapy in SMA or gene therapy in ADC deficiency by intracutaneous injection of the gene. So, but again, for all those diseases, and as said by my colleagues, so early diagnosis, early intervention, early treatment is crucial. Otherwise, even with the treatment, we'll be left with sequelae because the possibility of regeneration is extremely low. So, what are the challenges we have? So, I think, as my colleagues said, we have tsunami or West whole genome, and sometimes we don't know what to do with it. So, very important to have very good clinical phenotype, neuroimaging phenotype, biochemistry, and we have to do sometimes functional study, which is most of the time still lacking in our region. The second is we are dealing with expensive medication. This is medicine, expensive medication. So I think we have to have clear guidelines when to use or not to use those medications. In pediatric, we are facing more and more transition of care. So if you send a patient with metabolic or genetic disease. He's 20 years old. His weight is 11 kg. To Dr. Ali, I think he would start with him. So we are lacking metabolic and geneticists for adult patient, and this is most of our patients now are growing, and this is extremely important. And as said this morning by Dr. Zuhair, the national registry are extremely important. So this is my conclusion, just again to highlight that we need more multidisciplinary team between us as a clinician, geneticist, and other subspecialty. I think we have also to expand the newborn screening because we have now a new treatable condition, and again, prevention and counseling remain crucial for patients in the region.